So good morning, everyone. Let's get started. Thank you for being here so early in the morning. I'm Dr. Azoulay. I'm working in the St. Louis Hospital in Paris, and we are going to discuss about coagulopathies in the ICU. Of course, it's going to be a selected choice among a very large disease. So we will have to discuss, and of course, I will take some time for the questions, so then you will be able to go more into that. Well, we should discuss at the same time bleeding and thrombosis, because we are in a continuum, and it's very much alike. But now I selected to discuss only on bleeding and on very selected things about bleeding. But by the way, I'm going to show you a disease where platelet count is very, very low, but it is a thrombotic disease. So blood coagulopathies are very common. The most important thing is to start not by looking at the blood test, but at the patient. And this clinical approach allows you really to make the diagnosis immediately. Most of the complications are preventable if we anticipate them. We need to optimize the hemostasis with the optimal goal to minimize the blood loss and to avoid transfusion. And the most important thing, and this is really on a clinical practice a challenge, is that thrombosis and hemorrhage might coexist. So you have some time to do crazy things, and this is the things we are going to discuss today. So the clinical biological approach is based on the medical history. You need to identify whether there are drugs, whether there are medications, of course, whether there are antithrombotic and anticoagulants. The physical examination, because not everyone has a purpura, not everyone has an ecchymosis, and not everyone has active bleeding. It's really different. Purpura refers to thrombocytopenia. And if you have an overdose of anticoagulants, or if you have a real increase in the PT, so then you will have another clinical finding. You need to very quickly have a blood smear. Blood smear will provide you with the evidence that some of the cells are really central. So schistocytes that are broken red cells, I'm going to show you, and we are going to get back to that. Platelet morphology is very important because they can be thrombocythemia. You can have large platelets, and all of this really refers to a single diagnosis. You can also have smear dysplasia with either the leukocytes or other cells that are really dysplastic. Of course, you need to spend time to know, and this is mostly in elderly patients, to know what are the drugs they are taking, because some are direct anticoagulant and antithrombotic, but others are really indirect, leading to those abnormalities. And then you need to really spend time to evaluate the bleeding, because this is where it's going to take you. Because most of the bleeding have to be assessed, and the risk stratification is only clinical, because those patients are going to be hemodynamically stable over time. We can even imagine that the hemoglobin is going to stay very, very stable for the first hours. So you just need to know what's the source of bleeding. Is it surgical? So then, depending where you are, if you are after a terrorist attack, if you are after a bombing, or if you are after a car crash, it's not going to be the same. But you can do very simple things to provide hemostasis immediately and then run, because the concept here is to run to the surgery. If it's non-surgical, so then you are getting to what we call medical hemostasis with inherited coagulopathy, and this exists even in adult patients. You can have adult patients never diagnosed with a Wibron disease, and this is why I took this example today, with acquired coagulopathy that are really related to either a vitamin deficiency or an acute medical condition like DIC, or sometimes only indirect factors that we are seeing in the ICU very often, like hypothermia, acidosis, dilution, hypocalcemia. This can lead to coagulopathy. And then, of course, we have drug-induced coagulopathy. Everyone knows about the less frequent disease that is heparin-induced thrombocytopenia, but we know very little about thrombin inhibitors and all of those. So the important thing is that the same laboratory changes get to a different disease. This is one of the two papers that I advise you to read today. This is a paper written by Beverly Hunt. You will see her here in the conference. It's really an amazing piece. It's a very, very thorough writing and explained with good words. I like it. So Beverly provided this review almost 9 years ago, and you can see that the same changes, like for example, if you are taking the basic hemostatic blood test and different medical conditions like VK deficiency, antithrombotic liver failure, uremia, DIC, TTP, and hyperfibrinolysis, it's very interesting to see that you can have a clinical coagulopathy with normal blood test. And this is typically the case in aspirin or in uremia, where you can see that the patients bleed, but the hemostasis is going to be normal. So this is one of the figures that we need to keep in mind and maybe teach to our residents and fellows, because it's very important that we start with the basics. Sometimes we go to very advanced lab tests, it's useless. So let's take the same information, but seeing things differently. So you have assessed the patient clinically. You then have established whether the bleeding is surgical or not. And if you are in a medical coagulation disorder, you are going to look at the platelet to see whether it's peripheral with schistocytes. As you can see, this is a normal red cell, and this is a broken red cell. It's called a schistocyte. It's very easy to detect on a blood smear. You have to ask for them in some hospitals, where in other hospitals it's going to be provided by the counter automatically. Then you have the liver failure with the coagulation factors that are not produced anymore. And you have the typical DIC with all the thrombotic effect of DIC. DIC and TTP are really thrombotic disorders. Patients are going to die from thrombosis and from ischemia. When you are in low platelet counts or in coagulation factors, then you bleed, and it's very different. That we can imagine that we can have coagulopathies with low platelets or very low TP, but still a disease where thrombosis is first line. So we need to bear this in mind. I have selected two diseases because I really believe that this is striking. One is TTP, because we are the reference center for it, and I used to speak about it. And the other one is the disease that we miss the most in my department. So we need to think about it all the time. It can be acquired, it can be inherited, but the von Willebrand disease is really something we need to think about. It's rare, but it's not so rare. So TTP. You just need to figure out that this is the key factor. In 1992, a genius called Joel Mock in New York, he looked at a blood smear and he said, oh, I see platelets aggregated with something, I'm sure it's von Willebrand factor. And 4 years later, he and his group, as well as a group in Switzerland, published the description of what is the protein that cleaves the von Willebrand factor to make it shorter. Because if it's long, it's really aggregates the platelets, goes to the microcirculation and makes thrombosis. If it's short, because it's cut by Adams 13, then it is rheologically acceptable. So this is the receptor between the platelet and the Willebrand factor, the GP1B, and this is really the center of TTP. So let me go into the normal situation. Normal situation, Willebrand is short, and you can see it's independent from the platelets, and there is no aggregation. In TTP, we miss the enzyme that cuts the Willebrand. So the Willebrand is long. We call that UL, as usually large, okay? Unusually large, sorry, and this is really aggregating the platelets, and it goes to the microcirculation and makes thrombi and tissue ischemia. What is very important is that it is very, very easily reversible. We have now therapeutic alternatives that make that mortality that used to be 80% in 1990 is now 2%. But still, we need to make the diagnosis and to think about it. So what's the disease? It is a normal red cell. There is no disease of the red cell. The red cell itself is normal. However, As we said, there is a thrombi in the microcirculation, and the red cells makes like a car crash, and is going to explode. And what is a red cell that explodes? It's a schistocyte, a broken red cell. So you can see this is a schistocyte. This is a fragment of red cell after the car crash. If we have a car crash of red cells, we have an intravascular hemolysis. And as we have these clots made from platelets and Willebrand, all the platelets are in the microcirculation, and we have a deep thrombocytopenia. So then, this is called a TMA. When you have a mechanical hemolysis with schistocyte and the thrombocytopenia, it's a TMA syndrome. So then, from that, we need to assess whether the patients are severe, where are the organs affected by ischemia, and then we need to really understand that after we have seen the schistocytes and the thrombocytopenia and have made the assessment of organ dysfunction, we need to understand whether it's a TTP, which is an incidence for 1 per 600,000 people per year in each country. So, for example, if you live in Italy, there are maybe 250 cases per year of acquired TTP. Or if you have an HUS, a hemolytic and uremic syndrome. However, before getting to the end of the differential diagnosis, you need to rule out DIC, and we know that the clinical conditions are very different, sepsis, trauma, cancer, and maybe some others. So DIC is very specific. So this is why TMA is defined by having a normal fibrin and no DIC. So we really need to rule out DIC when we speak about TMA. And the second thing that we need to rule out, that is another thrombotic disease, is heparin-induced thrombocytopenia. But, please, as it is induced by heparin, don't ask the antibodies in people not getting heparin, because you are losing something like 740 euro for nothing. So HIT is really a thrombotic disorder that we need to think about it a lot, because in our clinical practice in the ICU, we give a lot of heparin, but at the same time, it's a very rare disease, and the typical case that makes that you are thinking about HIT is very rare. About 5% of the tests are positive. And we have very clear criteria. It's 210, not 012. So you need to see what is the thrombocytopenia, what is the timing compared to heparin one set, is there a clinical thrombosis, and are there any other cause of thrombocytopenia? And then you have a total score that is 6.8 is a hit, 0.3 is not hit, and here you need to think about it and maybe consider changing anyway heparin for another anticoagulant. So 0 to 3 has a very high negative predictive value. So if someone is on heparin and has thrombosis, this is really something you need to rule out. But then, when you have a TMA, you have assessed the organ, you need to get to whether it is a TTP, where Adams 13 is missing, whether it's a atypical HUS, which is actually a complement-mediated hemolytic and uremic syndrome, or whether it is a STEC HUS, which is a Shiga toxin from E. coli induced hemolytic uremic syndrome, like we have in preschool children and their grandparents when they are at Christmas and they go to the McDonald's. I have no conflict of interest with them. So the only way for you to make the difference between these three clinical entities is to assess Adams 13. All our countries have a lab that is either centralizing or organizing Adams 13 activity in our countries. So this is why we really need to know where it is. You are going to have a TTP in the next week, that's for sure. And HUS, we assess complement, but it can be normal even if we have hyper activation of the complement. And for STEC, we are asking one PCR in the stools as well as one serology. So the two are done. And then using Adams 13, we are able to stratify when it's really undetectable. Adams 13 is below 5%. So then we start the treatment for TTP. I must say that in adult patients with a TMA, because TTP is very, very likely, we would do a plasma exchange within 4 to 6 hours. 4 to 6 hours. This is how mortality went down to 2%. The very important thing is that if it's HUS, we need to block the complement system. The C5 blockade is usually done at the time ADAMTS13 comes detectable. And of course, we need to have a negative E. coli PCR for the patient. So then we would start eculizumab, which is a C5 blockade. If you have questions, I will be happy to take them. TTP has a standard of care, and since a few years, we have now, since 2017, but it has been released on the market in 2019, we have a very good inhibitor of the adhesion between the Wilbur factor and the platelet, that is caplacizumab, and I'm going to show that to you. So these are the clinical studies of ICU patients with TTP, and still, if we are having a lot of delay in making the diagnosis, patients are at very high risk of cardiac arrest and cardiogenic shock. Of course, it's a coronary disease, but it's microvascular. Unless the patient has risk factors for that, you are not going to do any angioplasty. And you might have also a stroke-like syndrome in those patients. So we need to be aware that mortality, when they are very sick, is still very, very high. This is a study where we compared patients who died from TTP to patients who survived. And one of the major differences was whether patients received a plasma exchange within 4 to 6 hours. But again, the very important thing here, you have 10,000 platelets, but the patients are dying from ischemia, mesenteric ischemia, stroke, and MI. And this is very, very important. This continuum between coagulopathies and thrombosis is really frightening. 10,000 platelets, but patients are going to die from thrombosis. Why don't we provide platelets to patients with TTP? Exactly. You give fuel to the disease because thrombosis is made by platelet, and everything you would give would go to the microcirculation and increase ischemia. So I wouldn't say it's forbidden, because if a patient has, I don't know, a hematoma or any very serious bleeding situation, I would provide platelets, but at the same time, I would do 1, 2, 3 PECs, plasma exchange, to be sure that I'm going to provide the patient with a huge amount of functional ADAMTS13 from the plasma, and then I will give platelets to provide a coagulation factor. But still, it's not something where I would say that in a typical year we have 25 patients with TTP, we have 120 TMAs, and we never transfuse them with platelets. So these are the therapeutic targets in TTP. So at the same time, you need to provide functional ADAMTS13. Today, we can only provide it using plasma. Tomorrow, there is the development of recombinant ADAMTS13 that is already used. There was a case in the New England something like 2 months ago, and you can provide recombinant ADAMTS13. Why isn't it a treatment, an easy treatment for acquired TTP in adults? Because we have antibodies targeted ADAMTS13. So it targets your ADAMTS13, but it also targets the recombinant ADAMTS13. So for inherited disease where there are no antibodies, it's the real miracle. It's really a miracle. But for others, maybe it's going to shorten treatment. We don't know. We need clinical trials, and anyway, it's not available for the patient. Then, as it is an autoimmune disorder, we are going to provide patients with immunomodulation. So all our patients receive steroids and rituximab, anti-CD20, to control the antibody against ADAMTS13. And then we provide caplacizumab that really inhibits the adhesion between the platelet and the Wilbur factor that is too long, unfortunately, because we are in a TTP. There are plenty of alternatives. There are other treatments, but they are very much specialized, second line, and we can discuss them if you want in question. So what we call the treatment is the triplet. The triplet includes ADAMTS13 through plasma. It includes steroids and rituximab, as well as caplacizumab. And now we are getting about 8% of patients with a composite score of cardiovascular events, but only 2% of patients who are dying, which is, for these very young patients, too much, and we need to be as close as possible to 0%. The other disease, I'm going to go quickly through it, is Wilburn disease. I don't know if I'm already at 20. Oh, I have 1 minute. So this is Eric von Wilburn, who described the disease in 1916. And it can be inherited, it can be acquired, but it is a disease that can be even documented in adult patients with mucosa-associated bleeding and bleeding after surgery or after a fall and trauma. We know that it's mostly related to a reduced level of functional von Willebrand factor. What is interesting is that we are again getting to the same thing. So we are again referring to the same GP1B receptor, and we know that when we have a vascular damage, normally von Willebrand goes to there and make cause. So it moves from this to this as a long, and it's going to aggregate and to produce the clot. This is the normal situation. We are in primary hemostasis. But there are so many different von Willebrand factors that I really advise you to have a consultant for that. We do that since 12 years, and I still miss the appropriate diagnosis because you need to see that every day. And this is why it's centralized. In our countries, we have 1 or 2 centers really centralizing the cases, and every time you discuss with them, you learn. But I must say that there are so many different phenotypes that it's very easy to provide the description. We are clinicians to provide the initial treatment. You can see here that according to the phenotypes, you are going to have very different prevalences of epistaxis, cutaneous bleeding, one that are bleeding, oral cavity bleeding, GI, anything. Tooth extraction is the typical way to diagnose von Willebrand, etc., etc. But you really need to be aware that this is a very simple disease, but you need to get, I would say, frequently to the diagnosis. But it is not normal to have a low TP in a patient, and we need to assess the patients by really evaluating how are the cofactors of the extrinsic pathway of coagulation, and then we make the diagnosis of von Willebrand. And to make the diagnosis, it's quite clear. We are going to really measure the von Willebrand factor antigen. We are going to know whether the platelet binding to von Willebrand is okay. So we are going to activate and to measure the activity of von Willebrand factor ristocetin, which is called von Willebrand factor RCO1. And the other thing, we are going to measure factor 8 activity, because hemophilia is always possible, even though it's not something that we are diagnosing in adult patients. But at the same time, you are getting to every different phenotype using this algorithm. It's easy. I must say that when I look at it, I can understand. But when I close my eyes, I forget everything. So this is why we need to really work with von Willebrand factor experts from hemostasis disorders. Management, I have nothing to say because this is out of the topic of today. I just wanted to show you one consensus statement. So this is the thing, is that if the patient doesn't bleed, don't transfuse. Nothing. The only thing that we would discuss is prophylactic transfusion before procedures of platelets, but this is it. Otherwise, there is this paper that I found honest and very informative that really provides, and this is the second paper I advise you to read. These are the European guidelines for managing bleeding and coagulopathy, and it's really straightforward. You have the bundles at different steps. You have the different steps to provide initial resuscitation, then to diagnose the coagulopathy, and then you have the different steps. I find it quite clear. I must say that because we have no robust evidence, this paper is the best that we can provide, and I really enjoyed reading it. So I don't need a conclusion. I think that it's common. It's quite complex if we are not taking clinical examination as the entry criteria. We have a limited diagnostic tools, so we need to understand them. We have little management strategies, and we need evidence, but this is a rare disease, and we are not going to get some more information about it with randomized controlled trials. Thank you, and questions? Any comments, questions? I'm ready to fight if you want. Please.
If you get a patient with schistocytes and low thrombocytes and you suspect, so you have some kind of TTP, we usually place the dialysis catheter and start and take the blood samples and everything, wait for the ADAM13, but our laboratory takes like 12, maybe 24 hours. So we start the plasma exchange with fresh frozen plasma.
100% of fresh frozen
Yes,
plasma.
yes, always.
Blood mass is 60 milliliter per kilo.
Yes, okay, so we do that, and when we get the results, we then suspect if we have TTP or atypical hemolytic uremic syndrome. And in the past, I don't know, 1 year, we had 1 or 2 patients that were with normal with normal ADAMS13 and didn't have any detectable genetic abnormalities.
50 to 60% of the patients
Yeah.
are having one, but we didn't yet identify it.
Okay, so my question is, we continued for some time with the plasma exchange. We gave the corticosteroids, and we went to eculizumab. So what's your opinion on that, and to which patients eculizumab, and to which patients caplacizumab? And the price also. I'm from Croatia. So.
Yeah, caplacizumab only in TTP. When ADAM13 is undetectable, well, of course, we have to balance that and this evidence as compared to all the public health issues we have in each country. If in my country it's in the rank 5, so it's not a drug that is considered to be life-saving. But from my experience of someone having TMA very often in my department, I would say that it has changed the scope of the disease. And you know, it's a so nice drug that is going to be applied in many different diseases that I like it. Well, if I were in a country with limited resources, I would not give caplacizumab, or I would give it in very selected patients. I would select, for example, patients with very high troponin, because I don't want patients to die from MI, and I would maybe select young patients as compared to older patients. We know that older patients respond very well to Capla, but this is very expensive as compared to life expectancy. So I would reserve it for those patients with autoimmune disorders and are quite young, in their 20, 30. And no, only when there is TTP, so ADAM13 is undetectable. When ADAM13 is detectable, it's an HUS. It's not a TTP anymore, so no Capla. But then you ask something that is very important. If you want to go to the flow of HUS and do eculizumab, which is a C5 blockade of the complement system, so then you need to be sure that you don't have a secondary TMA, drug-related, autoimmune-related, or a differential diagnosis like malignant hypertension. Malignant hypertension is really providing a typical case of HUS or scleroderma crisis. So if you're outside this, then you go straight away. But you need to rule out Shiga toxin from E. coli. So when you don't have a secondary TMA and Shiga toxin is negative, caplacizumab is really a drug that changed the scope of the patient. There is a paper from Norris, Norris, in a clinical journal of GSN, and it's a very nice paper that shows that patients with HUS might survive, but they are going to go to transplantation because they are really with end-stage kidney disease. So I would say that it's the same. If I were in a country where where I need to do priorities, I would not do priorities to that. I would vaccinate the kids. I would take care of women, pregnant women, and healthcare of pregnant women. I would give maybe more access to vaccination to healthcare providers. I would care burnout for healthcare providers much more than Kaplan and ECU because of the cost and because of the emergency. But still, it's a disease that has transformed. It's a drug that has transformed the disease. It has really saved the kidneys. It has really improved the TMA. And when you look at the patients at long term, it's really interesting. By the way, eculizumab is a C5 blockade. When you do eculizumab, you do 3 things. 1, you provide oral prophylaxis against meningococcemia because you decrease complement system, so patients become immunocompromised. 2, you vaccinate the patients with the 2 strains, meningo A, meningo B, so 2 vaccines. And 3, you provide the patients with a cart, so if something happens, in the paper, you see that the patient receives eculizumab, and you know that it's a septic shock or a meningoencephalitis related to meningococcemia. Any comment, question? No, we don't, because we give oracillin, oral prophylaxis for 1 year. And usually after 1 year, we make the decision whether we pursue eculizumab or not. It will depend on genotyping. There are some genotyping phenotypes, genotype by the way, that are really associated with a prolonged need for eculizumab and others not. So we need to decide. We also need to decide on whether the patient is going to want a pregnancy or things like that. So we make the decision with the patient in outpatient consults. Any comment, any question? I think we still have 1 minute. No, we don't have 1 minute. So I wish you a very nice conference.